Hello everyone, I'm Dr. Joanna Nixon.
And I'm Dr. Vilma Pacheco Barcia, and this is Open Doors Podcast, two women scientists driven by curiosity and compassion.
Welcome back to Open Doors, the podcast where we explore professional well-being in oncology and beyond, one conversation at a time. Today's episode brings together science, social justice, and sustainability in medicine. We will talk about lung cancer in young patients, the invisible weight of burnout in academic oncology, and how opening doors for underrepresented communities can change the future of care.
We're truly honored to welcome Dr. Narjust Florez, co-director of the Lung Cancer Program, Associate Medical Director of the Cancer Care Access Program, and Thoracic Medical Oncologist at the Dana-Farber Brigham Cancer Center. First completed her internal medicine training at Rutgers, New Jersey Medical School and her fellowship at the Mayo Clinic in Rochester, Minnesota, where she also received fellow. Her clinical work focuses on targeted therapies for lung cancer and the care of young individuals and women with lung cancer, survivorship, and sexual health. She is the principal investigator of the Young Lung Cohort Study, the largest prospective study today evaluating the unique characteristics and outcomes of young individuals with lung cancer.
Beyond her clinical expertise, Narjust is nationally and internationally recognized leader in cancer health disparities, gender and racial discrimination in medicine, and equity in medical education. She has received numerous awards, including the Resident of the Year Award from the National Hispanic Medical Association, the Mayo Brothers Distinguished Fellowship Award, and the LEAD National Rising Star Award.
In 2019, she founded the Florez space dedicated not only to lung cancer research, but also to social justice in medicine and building inclusive environments for trainees from historically represented groups. The lab's mission is clear. Its members of change. Dr. Florez, clinician, scientist, mentor, and advocate. Open Doors podcast.
Thank you so much, Dr. Pacheco Barcia and Dr. Nixon. It's truly my pleasure to be here to have this conversation, and most importantly, to share the mic with two amazing women in oncology. I think this is a treat that you get to have the three of us. So looking forward to this conversation.
Thank you so much. It means a lot. Whoa, your CV is truly amazing. Diving into lung cancer and stereotypes and perceptions, many people still associate lung cancer almost exclusively with smoking, tobacco use, and older age. Yet in clinic, we still see something different. Can you tell us about the reality of lung cancer in younger patients who have never smoked?
Yes, it is my pleasure. Take home message is the face of lung cancer is changing, and it's changing fast. So in 2018, for the first time, we saw published data that shows that younger women are getting lung cancer at higher rates than men. And this is the first time in history ever, regardless of tobacco use behaviors. So when we look into the data even deeply and we remove the smoking, as a bias, I call it the smoking curtain in reference to the Iron Curtain for the Cold War. When you remove that, when you remove the tobacco exposure, 66% of the patients with lung cancer are women. So in fact, lung cancer is a disease of women intrinsically when we remove the tobacco as a risk factor. As we see the demographics of lung cancer change to younger patients, it's expected that by 2030, and 2030 is only 4 years away, right? We're at the end of 2025. 1 out of 5 patients diagnosed with lung cancer is going to be less than 50 years old. That's 20% of the patients. However, due to the stigma associated with the disease, we still don't talk enough about young lung cancer. We still don't talk enough about lung cancer in non-tobacco users. So the demographics are changing by age. Gender, it already changed. That already happened. This is for cancer registry data dating all the way back to the early 2000s. In addition to that, gender, we talk about race and ethnicity, because Hispanics are also a highest risk, one of the highest risks after Asians to be diagnosed with EGFR lung cancer. So we cannot see lung cancer as the disease of the white all why all men. That is not true. That has changed. Yes, there's still people with tobacco use that get diagnosed. Yes, there's still the majority. However, things are changing. It's very important to understand this change because the perception can delay diagnosis. And we have studied that in our lead study that showed that unfortunately, younger women with lung cancer are often misdiagnosed with anxiety. And that is the intersection between age and gender, because women cannot have physical complaints, they're anxious. And that leads to delays in diagnosis. So many of these young women are being diagnosed with stage 4. So the demographics are changing, but we are not there. The society, the medical society as a whole, still don't see lung cancer for what it is today. And that leads to delays in diagnosis. And it leads to many patients not having the option of a cure because they're diagnosed with stage 4.
There's a lot of data and something very important, the stigma, because it is emotionally, and especially as you were saying before, young women. I want to ask you how, well, at your approach, how does this affect patients emotionally when they're diagnosed with a disease that often assumes it can be self-inflicted?
So lung cancer is the cancer with the highest stigma, period. Higher even than cervical cancer. So the issue with stigma, so let's define stigma for your audience. Stigma is a negative perception or association with the disease. And that leads to fatalism, that leads to isolation, that leads to depression. And it's more than harm feelings. Stigma is not only about harm feelings. Stigma affects the patient's journey from diagnosis to the end of life. So I'm going to give you an example. When a patient with lung cancer shares the diagnosis with a friend, the first thing they get asked is, "Did you smoke?"
Mm-hmm.
Right? There is no empathy in that question, right? There is no empathy. I just told you I have cancer. But when a patient with breast cancer discloses that they have a breast cancer diagnosis, the first thing they hear is, "I'm sorry." Right? So instead of being a blame or "Did you smoke?" they get "I'm sorry." They get empathy. So that's why many patients with lung cancer completely avoid disclosing their diagnosis because they are tired of explaining. Especially for the younger women in my clinic, they're done. They're like done. I think some of them still have the energy, but you're dealing with cancer. You don't have to be explaining to every human why they're so stigmatizing and biased. So, however, the stigma associated with cancer and data in several studies, many of them led by Dr. Stoops at the University of Colorado, he was previously in Kentucky, showed that the stigma associated with lung cancer increases the chances of depression in these patients, increases the chances of suicidal thoughts, and induces social isolation. So this is more than harm feelings. In addition to that, we keep feeding on the stigma. A patient checks in into the clinic, and they say it's not the oncology clinic, it's the dermatology clinic, because you still have to go to the dermatologist. And they say, "Any new diagnosis?" Well, I've been diagnosed with lung cancer. That medical assistant will say, "Do you smoke?" Right? That's the first question. Then the nurse comes to do the medical reconciliation. "Any new medications?" It's like, "Yes, alectinib." What is that medication for? For my ALK positive lung cancer, which is almost exclusive in non-tobacco users. What the nurse asks, "Do you smoke?" Right? And then the dermatology comes in and learns that his patient for 20 years now has lung cancer. And the dermatologist asks, "Do you smoke?" So it continues to feed on it. It's a never ending cycle for many of these patients. So many of them shut down and they stop. And that has come to a point that I have patients that have told their family that they have bone cancer because the lung cancer metastasized to the bone. And I have patients that tell their family they have breast cancer because it's easier. And that is extremely unfair because you're already dealing with a bad diagnosis. Why do you have to also lie to society and lie to your family because of the stigma associated with the disease?
Thanks. And this is so important to share, especially with the medical community, with everybody who is supporting these patients in the way of communication and how we can basically advocate them. I have to disclose I don't treat lung cancer, but I am aware of all these issues, and not being able to share your diagnosis because of stigma is really, really, really difficult. From the clinical side of things, from a clinical perspective, Narjust, are there any unique biological or molecular features you're seeing in these younger non smokers?
Yes, 100%. So the first thing is that the biggest improvement in cancer mortality has been thanks to the introduction of precision medicine to lung cancer. 15% decrease in mortality at 5 years. No other cancer has been able to reach that so far with precision medicine. So we were in such a need because the overall survival used to be 6 to 12 months. And many people, including one of my mentors, were able to find these targets. And these targets are very common in non-tobacco using younger patients. So these targets are driver mutations. They can be the result of a translocation, they can be a result of a mutation. Most of them are somatic. So most of them are secondary to the interactions with the environment. Only 1% of lung cancer is hereditary or germline. However, the number may go higher. Dr. Jackie Lopiccolo at Dana-Farber is doing a large study to understand the inherent effects. We did think they may be more polygenic. However, back to the targets. This is, for example, the fusions. It's a break-apart fusion that happens in the ALK or ALK gene that induces the tumor for growing. Young patients are 6 times more likely to have a target mutation than older patients. Why? Because they didn't have the exposure and they didn't have enough to be all enough to develop the cancer through a secondary exposure. They have something intrinsic, these mutations, these rearrangements that induces the cancer from happening. The three most common mutation in younger patients is ALK, that is a break-apart fusion or rearrangement. Then we have KRAS G12D, D as in David, no associated with tobacco, and EGFR, which is the first one. EGFR was described 20 years ago for the first time, and therapy has evolved significantly to improve survival from 6 months to now we're talking about 4 or 5 years. But younger patients are most likely to have a genomic mutation. Unfortunately, these mutations are often make the cancer cells trophic for the brain. So a lot of these patients have brain metastasis at diagnosis. As we talk about it, people tend to gaslight these women, and I'm using the word gaslight because that's what happens. Gaslight these women so they don't get diagnosed until late, so they have a very large symptom burden when they're diagnosed. And another unique characteristics of the disease, besides the brain metastasis, is that we often see small tumors and big, large lymph nodes. So the intrinsic biology of the disease is rather aggressive, that even a 1.5 centimeter tumor can give you a bunch of lymph nodes. So you don't need big tumors for a lot of lymph nodes involvement compared to other types of cancer.
Thank you so much for sharing on that. Also, because I think it's very, very important, as Joanna was saying before, to talk about this population of patients non-tobacco use and how different they are at the clinic and the management of them. So thank you so much for sharing on that. I would like to also move on to survivorship because all therapies have been evolving in the last 5, 10 years. We've seen more survivorship in patients. Been a pioneer in bringing attention to survivorship issues that are often overlooked, especially sexual health. What led you to launch the Shaw study?
I think the launch study dates back, unfortunately, to a patient. I remember I was at the Mayo Clinic at the time and I saw a patient that had armpit excoriations. And I was wondering where those armpit excoriations from. And then I realized that that was a form of intercourse that she was having with her husband because vaginal penetration was extremely painful and because oral sex was nearly impossible because she had very dry mucus. So they were using the friction of the axilla to produce some type of intercourse. And I was like, this is not right. Because if we were talking about vaginal dryness, we can easily fix it. And then I start asking more and more patients, and they're like, oh no, we haven't had sex in 2 years. And with the new therapies, Dr. Pacheco Barcia is insane that with new therapies, patients live in 10, 12 years. Are we expecting these women to be abstinent when we know all the benefits of sexual health? So I often like to say I brought the word vagina to lung cancer because before that, people didn't talk about vaginas. And I made it my mission for 2 years that every time I started a meeting, I would say, let's start with the word vagina because we need to normalize it. We all came through one or were involved in some form or shape in a vagina, right? At least you came from the Holy Spirit, a vagina was involved. So it is a beautiful organ like the liver. So the first step was to talk about sexual health. That wasn't discussed in lung cancer. So that was very important. And then we understood that the what we learned in the Scholl study is that 77% of the patients have moderate to severe sexual dysfunction. 77% of the patients. And it's important to mention that we did this study in the peak of the pandemic. The IRB approved was like in February of 2020. Little did we know that the world was going to change. And we still were able to recruit over 200 women in the middle, like peak pandemic, not like baby pandemic, like no vaccine pandemic talking. So we learned the sexual dysfunction at high rates, but we also learned that it's not that complex. The number one issue was vaginal dryness. And then the other issue, as besides vaginal dryness, that we thought was oral mucous dryness and body image. So while there are a lot of interventions, lubricants are not that expensive, moisturizers. And it's important for your audience that both and moisturizer are different than vaginal lubricants, right? You need both. And that you can learn from other colleagues. But the take home message is that the word vagina belongs in lung cancer.
Thank you. Very, very important topics. And I think this involves, to a degree, cultural differences. I practice in the UK. And as you were talking, Narjust, I was just thinking I don't have a lot of female patients, but I've done quite a lot of HPV positive head and neck cancers, and you know what that involves in terms of discussing about sexual function and questions from the patients. And I'm also a prostate cancer specialist, and sexual dysfunction is something that we very, very frequently talk about. And it's really important because it can impact on the quality of life. Why do you think, I know I mentioned cultural differences, but why do you think sexual dysfunction is still neglected in oncology? Is it something that we as clinicians don't feel very comfortable talking to our patients about? Why do you think that we don't talk about such an important topic of quality of life?
I think, like anything in medicine, this is multifactorial. I think the number one thing is that we get no training. We get no training in oncology. So we spend hours and hours learning how carboplatin works, how the microtubule is like producing instability by the taxanes, how immune checkpoint inhibitors work, hours and hours. And maybe if we were lucky, we get one lecture on sexual health. Maybe. And that's if you make it. Because if you're in Heme consoles, you didn't make it today lecture, right? So we don't get training. So we're always afraid of something that we don't know. And we don't know sexual health. Eh, I think certain subspecialties in oncology are more comfortable. Prostate cancer, as you mentioned, breast cancer, GYN malignancies. But so what happens with the rest of patients? Because it doesn't involve a reproductive organ or a genital organ, then there's no sexual health. So number one is the lack of training. And number two, it has to do with the stigma, particularly with women's sexuality. And I'm going to give you a little fact that you probably didn't want to know, but now you know. We decoded the human genome before we fully dissected the human clitoris, the female clitoris, because religion, cultural differences, many, many reasons prevented that from happening. The penis had been dissected since the Greek times, but we didn't fully understand the clitoris until like a few years ago. So we are so behind in science, understanding women's health, women's sexual health, that leads to this gap in this whole stigma or myths about women's sexual health. And then you put lung cancer on top of that, which is a disease that has her own stigma. It just leads to a bad combination. So, lack of training, the stigma associated with sexual health, the lack of understanding of women's sexual health, because the show was for women. Because as you know, in every NFL game, there is some type of Viagra kind of commercial, right? But there is not a lot of research on women's sexual health, very limited, because the woman's pleasure has always been downgraded by society. or reproductive capacity has been prioritized. So I think all of that leads to this unmet need. However, having this conversation is already doing a lot. I have a bowl full of lubricant in my clinic, and it's a good conversation starter. Having just that bowl of lubricant. I know a GYN and a thoracic oncologist, but just having, they're like, what is that, candy? It's like, depends how you see it. Then I make them laugh, and that opens the door to the conversation.
Yeah.
Yeah, I think it's a very important topic. And as you were saying, Dr. Flores, we're very used to seeing this topic in breast cancer, maybe even prostate cancer, as we're previously explaining. But I think it's very important to raise awareness in cancer and other types of cancers. And I wanted to ask you, before going to the next part of our conversation, about would you recommend other colleagues if they want to start talking about sexuality in their consultation? How can they start that approach with patients to really help them improve quality of life?
I think talking about sexual health is like going to the gym. And here we're in December, right? So, what do you think is like going to the gym? The first thing you go to the gym is painful. You're there, you're self conscious, everybody knows how to use the machines, and you're like, should I stay home? That is what happens when you start talking about sexual health. You're not used to it. It's like the first time in the gym. But the more you go, the more comfortable you feel. And I always recommend coming from a place of honesty. Like, this is not my specialty. I don't know anything about this, and I don't know everything about this. However, I want to ask you, you don't have to see sexual health. You can see how's intimacy. And you can do it just one on one. I would recommend to doing one on one instead of with the partner in the room, because it just means a lot of pressure to the patient. Later, you can ask, as we continue to have conversations about sexual health and intimacy, do you want your partner to be part of it? But the first thing is, how are we doing down there? How is this going? And one perception that I think we have to eliminate is that all sexual health is intercourse. That's only like 10% of what sexual health is and intimacy. It's about cuddling. Do you have enough saliva to kiss? Do you have enough saliva to perform oral sex? Do you feel okay with receiving oral sex? Right? Because chemotherapy causes a lot of yeast infections, right? And women are very self conscious. Anal sex, any form of foreplay. And the most important sexual health is the sexual health with yourself. That's what I start talking to my women. It's like, we are not going to fix this problem if we think this is a problem we have to fix with your partner. This is
Hmm.
you. So let's rediscover your new body. I always tell my patients, let's rediscover your new body and get butt naked in front of the mirror. And I want you to tell me or tell yourself, not me, 5 amazing things that you see in your body. If you see that port, that's a sign that you survived the chemotherapy. That
Hmm.
is a sign that you were able to get that, right? That is no weakness. That's like a warp scar. You should be proud. Do you have a mastectomy? Do you have a lobectomy? You have a very large incision. Do you have a diaphragmatic paralysis? Or, you know, it doesn't look good. Do you lose your hair? Start to love your body, because women's sexuality is very linked to how we feel about ourselves before
Hmm.
anything. So look, I tell my patients, look yourself in the mirror and tell yourself 9 things, because society has told women, regardless of cancer or not, that we're not enough, that we need to look this way, that we need to do this way. This is the
Hmm.
opposite of what the message go to men. Men is like, exists. And there's a Colombian comedian that has a very fun show. And the character in her show is called Ramiro. So Ramiro looks himself in the mirror and he's like, Ramiro, I'm so good. And then Maria goes to the mirror and she just lists all the things that are wrong with her. So sexuality starts with self-love. And sexuality in the cancer clinic starts with open-ended questions and acknowledging that we're no experts, but we know who we can refer to. Can we talk about intimacy for a little bit? That's how you can start the conversation.
I truly love this. And what we say in the UK is that there is life with and beyond cancer. And in a way, you normalize what is happening. You talk about self-acceptance and self-love, and that's the first step. Because people frequently don't open up or don't feel that in all of that, during the diagnosis and the hard treatments and all of what they're experiencing, including fear about their life, they think that there's no place for that. There's no place for normality during this time. And having a clinician like you opening the door to these conversations is really important. So thank you so much for touching on that.
Yeah,
And talk,
we need to eliminate the
yeah,
times of dry vaginas. No more. No
yeah,
more.
yeah. No, no, and it's very liberating talking about these concepts, because all of that certainly does not apply only to women with breast or lung cancer. As you said, it applies to a lot of women. So I think it's important that we open the door to more self-acceptance, self-love, and more positive body image, and appreciate how we feel in our bodies. um I'll take you to a very similar subject but different at the same time, around self-care and self-love. We frequently talk in this podcast about burnout and how that feels and how we can prevent that. And we know from recent data presented in international meetings that they showed alarming rates of emotional exhaustion, depersonalization in early career thoracic specialists. So, from your perspective, what do you think is driving burnout?
I think burnout is a mix of many things. One is that we have forgotten why we went to medical school for, and it's to help people. We start adding up tasks that has been lost to the original mission, right? The original mission, what we, the three of us went to medical school, was to take care of people. So then we started having this narrative, protected time. Protected time from who? The person that you sacrifice your 20s to care for, right? The narrative has completely changed. You are a number, you're an RBU number, you are a publications number, you're an H index number. No, I'm a doctor before anything. And it has taken me a lot of time. Oh, Vilma and Joanna, I've been burned out once, twice, I think probably twice. And burnout is more like is a recovery big down phase. And I think the pandemic really significantly added to many women and many chances for burnout. But we have forgotten the mission. And we have created these metrics that we compare to our peers, or we are compare. We compare ourselves, or institutes compare us to our peers by these metrics that are away from the mission, which is take care of people. So I burned out because I thought $4.5 million in funding was not enough for my lab, right? What metric is that? I remember dreaming of having $50,000 grant. Now 4.5 million is none, because the bar continues to move for us. I remember getting a huge grant, and in 2 days I received an email from a leader and told me, "Oh, here's another one to apply." And then I went and started working in that grant. So I didn't even have time to enjoy my first multi-million dollar grant because there's another bar set. There's another thing to do. Oh, you have one member in your lab, you need two. You need three. Or you need that. And then I just, this May, I'm not going too far away. This May, I was about to lose it. My team was entirely turning over because I'm very, very fortunate to have amazing people on my team that always go to their next journey, which is medical school, PhDs. And then I needed to write more grants. I needed to get more publications. I needed to run for the board. I was planning a wedding. My father comes for his cancer diagnosis. So there's so many stuff that I remember crying in the shower. And this is May. I'm not talking about, when people talk about burnout, they're like, oh, back in my old days. No, no, girls, I'm talking about May of this year. And it was nice in Boston. The weather was nice, and I was crying in the shower. So I think it's just because we have to remember what we went to med school for, and all these bars and all these things. And I don't know when or how I decided that my inbox needed to be a zero,
Hmm.
like 5 years ago. And that led to my burnout. I was,
Hmm.
I remember saying like two more emails and I would get to zero. And I would answer those two emails and then I would get two responses back and back to never zero. So It led to our own. Vilma is laughing because she knows. And this is not only email, it's the in basket for the medical record, is the other messages that you get and other platforms. So I don't know who said it needs to be level zero, like zero. And I think also women's we're strong, we're hard on ourselves because we have to be twice as good to be considered equal. So yeah, I think I talk about burnout because I've been there twice, but you can come out of it. And thank God for SSRIs. We got to talk about it. God bless SSRIs. I'm an oncologist. I think every oncologist should get a therapist. Not everybody, but pretty much. We deal with such
Mm.
a
Yeah.
last Thursday clinic. I'll tell you, last Thursday was one of the biggest roller coaster clinics I had. I have a 33-year-old complete response, no evidence of disease, stage 4. Yay! We're celebrating. Then I have a 28-year-old that I think has a few weeks left in his journey. And then I have a 36-year-old doing amazing. And then I had a patient that wasn't doing good. Like, that's not normal.
Mm-hmm.
Like, we have normalized that, but nobody goes through those emotions in their lifetime. And we go through those emotions in one day. And at the end, we need to finish our notes. So that's what I think burnout in oncology is so high.
Hi, thank you, Narjust, because you were sharing and I was getting like emotional because all of it you said really resonate. It's true that these huge standards and we just want to be the best. And when you if you like take a moment, my psychologist always says this to me when I'm overwhelmed. She's like, okay, let's recap 5 years ago. What did you want to do? Your dream. Well, where are you now from your dream? You're where you wanted to be. So we really don't stop a second and say thank you for this moment, all the work I've done to get here. So I really believe that we set the bar so high. We all do in medicine, women, female leaders. Like we're always trying to be better. So I'm really emotional about what you shared right now. Resonates. And while you were also explaining, it reminded me of syndrome. Imposter syndrome is something we're actually revising right now on young oncologists and seeing how it be linked to burnout, to depersonalization. Imposter syndrome is a problem we face in this bar, getting high. We want to be better, and when we do something good, we're like, do I just have I done enough? That double mirror. So I wanted to ask you, think about the impact imposter syndrome has in early career oncologists.
I think mixed feelings about imposter syndrome because I'm crippled by it. However, I try to channel my inner Rihanna. So people don't know I suffer from imposter syndrome because I channel my inner Rihanna. So Rihanna said she just fakes until she makes it, right? And she always said that. She always has this attitude. Why do we love Rihanna? Because she has this attitude that she got it. She's gonna kick ass. But many times she has said that she's insecure inside. So sometimes I just channel Rihanna, but the imposter syndrome is in the back. So I had me feelings about it because it is often an excuse for behaviors that can be modified. And I found it that imposter syndrome is something that we mention often to justify how society has makes us feel as women leaders. I think it's a syndrome that is the diagnosis of what we don't supposed to be. Because, oh, it's my imposter syndrome. No, it's that you were told by society that you couldn't be this way because otherwise you were the B word, right? So I think imposter syndrome was caused more than I appear. It was caused by all these societal roles. So if I'm very assertive, then my imposter syndrome is not affecting me. No, never mind. She is very aggressive. There's a meme that you probably have seen. It's like, what is the difference between being aggressive and assertive? And the only difference is the gender. So I do think imposter syndrome is the diagnosis of society pushing us to feel bad about being leaders because we're supposed to be nurturing. We're supposed to be that. And 66% of women are reported, 66% more women are reported to leadership or human support resources compared to men in academic medicine. So when you leave your imposter syndrome behind, then you get punished. And when you let the imposter syndrome
Mm,
take over, then you get punished. So we just don't win. So I
yeah.
Rihanna that out. I go and Rihanna that out on the stage. And you're not gonna like me if I'm too shy, and you're not gonna like me if I'm too Rihanna. So I better Rihanna that out. So at least I can, maybe get a Fenty brand one day. Sorry,
I
sorry, I
love
should
the
make some
goodies.
brands here.
Yeah, no, no, I love this. I love this. And I'll take a step back because when I was listening to you talking about the email dragon, as I call it, I remember at one stage a few years ago, I had a lot of senior management responsibility, and I was so furious with the amount of emails I would get, clinical, academic, managerial, and I counted them. I counted them, and it was over. I would get over 350 a day, 350 a day, and the only way I would cope with that, because like you, Narjust, I just wanted a zero. I didn't want to have any emails that I didn't reply. I would be 24/7 serving the email box, which is you can't sustain really, can you? In terms of mentoring, you do a lot of work. What do you see as protective factors helping young oncologists to stay connected to purpose? As you said, why are we in medicine? Why are we there?
Why are we like connecting the next generation? I think it's our duty to prevent the same trauma that we had. I cannot
Hmm.
protect my mentees for all the trauma that is out there as a woman of color in oncology. I can't. But at least I can create an environment that they feel comfortable to tell me
Yeah.
what they experience out there, which I didn't have a safety environment. I didn't have that. So even just by creating a space, by having a group chat, I have a group chat with a lot of my mentees, a text chat, and they feel comfortable because sometimes just letting it out with people that get it, right? My husband, love him to death, but he doesn't understand because he's not in this little cult that we all belong to, right? We all belong in this little cult, and at least you're in, you don't get it.
Yeah.
So creating a safe environment is one. So I cannot control the interactions that we have, but I can provide the environment and I can help them how to deal with the microaggressions. Because microaggressions are permeated and people will remember them for years, but how to deal with them. And the one thing that you and everybody does that we forget is role modeling. Role modeling is a beautiful way of mentorship. So when I show up with a red suit and I do not care, and I'm the youngest board member, and I show up with a red suit, I know somewhere there's a Latina student or resident that say, I can show up with the colors that I like. I don't have to be
Mm.
in the same blue, navy, brown. Dr. Flores has red. I remember hearing somebody one day saying like, but I'm just gonna wear my hair curly. I stopped straightening out my hair like over 10 years ago. This was a lifestyle. And every time it rained, affected my quality of life because I will become Mufasa from the Lion King when it rained.
Mhm.
So
Yeah, that happens.
I think role modeling is a very effective way of mentorship that we often take for granted.
Thank you so much, Dr. Flores, for joining us today. It has been a true pleasure. All of these topics that I'm really sure are going to be very helpful for our audience.
Thank you for the invitation. It has been a wonderful conversation.
Thank you so much. It was an honor to have you. Thank you.
And to all our listeners, keep opening doors for yourself and others.
Dr. Joanna Nixon.
I am Vilma Pacheco Barcia from Open Doors Podcast.
And remember, you belong in the room.
You belong in the room.